inadvertently a lot with how we're going to talk to our patients, how we're going to get the lay of the land for that patient before we decide to dose them. This is one of those medications, and this is a category where we're going to be very careful because of the side effects with these medications on how we're going to dose our patients, all right? So patient history, other medications that they're on, comorbidities are going to be big deals because they're going to drive which medications you choose in these patient populations, okay? So a lot of this stuff is not going to be as black and white how you would want it to be. But whenever I am testing you on this, I will try to make it as obvious as possible with which way, if it is something like a pain scale type of thing that I'm going. So you won't have to like super stress about that. ELOs, same thing. All right, so talking about our opioids, essentially what our opioids are doing, oh, sorry, time out. This was another question. When we're talking about anything that is pathophys, if you see the word pathophys, I'm not worried about that on my test. Same thing as how it was with Major Sternberg. If there is something that is going to be in the beginning that I need you to know, like for a test or like it's a question that's on the test, I will let you know, or it will be in the review. Okay? Okay. So essentially what our opioids are doing is they are binding the same receptors as our opium does, and opium are essentially naturally occurring things that we have in nature, and they found out, hey, this helps with pain relief, and then we decided we are going to try to modulate that or mimic what we see in nature that is causing this pain relief and modify them in ways that we can try to decrease the side effects that we are experiencing when we take it naturally, and make them better, kind of like what we did with our non-opioid medications. That's essentially what you're looking at here. So our clinical uses, moderate to severe pain is essentially what you're going to be doing. If somebody is coming in with mild pain, we are not jumping to any type of opioid. You're going to hit them with some Tylenol or NSAID or some physical therapy or a little prayer and a wish that they feel better, and you'll send them on their way. We are not giving them an opioid, okay? So if you see a patient who has some mild pain, they will not have anything that is going to be what we talk about today, okay? So moderate to severe pain. Also, you'll see it used for coughing, anti-diarrheal medications, because we'll get into that a little bit later. For patients who have opioid use disorder or dependence, you see it to help them minimize how much they're having withdrawal. You can also see it used in combination with opioids to kind of deter patients from abusing it, crushing it, things like that, and trying to get high off of them. So you'll see opioids in that way. Our role in therapy, a lot of this is going to vary because, again, depending on what your patient is presenting with is going to be why we're going to use these medications, right? So acute pain, something that might be breakthrough pain. Sometimes when you have a patient who has acute pain, you'll have to give them like a long-acting medication and then give them breakthrough on top of it if that long-acting doesn't work throughout the day. It's very common to do. We'll talk about that when we get to the dosing part of how we're going to dose our opioids. And you see here that it says cancer pain and not non-cancer pain. When we're talking about opioids in non-cancer pain, they don't want it to be something that we're using for a long period of time. In our cancer patients, though, a lot of them will be on opioids long-term, and you'll have to switch them sometimes in different classes because of the fact that they will develop tolerance over time from them being on it. You'll have to increase doses. A lot of times with these patients, you probably will end up sending them to a specialist, but just be very compassionate with them because of the opioid crisis that we're going through. A lot of them have a lot of trouble getting their medications from the pharmacy. A lot of pharmacies were turning patients away who had cancer because they thought that they were drug seeking. So just be very understanding of what's going on with your patient. Listen to what they're trying to tell you. Some people, yes, they may become addicted to it, but at the same time, they are in a lot of pain, okay? So trying to balance those two and figure out what your patient really needs. Neuropathic pain, for the most part, we don't use this for that. because then that would mean that you're going to be putting them on one of these opioids again for a long period of time. We'll usually use one of our adjunct medications like our gabapentin and some of the other things that we talked about, our pregabalin instead, before we jump to an opioid, okay? Our monitoring, of course, we're going to monitor their pain. Do I need to take them off? Are they becoming more controlled at this point and I don't need to have them on a dose? Can I start tapering them down? If it's something that's acute, how long are you going to prescribe? Like what day supply are you going to supply that patient, okay? If I did something that is considered like acute pain or an acute trauma, it's not something that's very bad, don't give me 30 days worth of my hydrocodone for me to go and sell it, right? Like I probably need 3 to 5 days. Like just take into consideration what is going on with the patient and understand that the longer that you leave them on, the more work you're going to have to do to taper them off, okay? So short duration, low dose is what we want to do with this class of medications because of the fact that you have a lot of side effects and CNS depression and other things that can happen when they're using these medications. So GI side effects, that's due to some of the opioids and the receptors that they hit will cause some types of side effects sometimes. Also, they're used in combination with Tylenol as well, so depending on some of them. So depending on which medication you give the patient, that's something that you'll also have to monitor and consider. Your O2 sats, because we can have respiratory depression with these, and then other medications because, again, interactions that you can have with what's going on when you're giving your opioids. So essentially, the mechanism, we've seen this picture before, is more so focused on the bottom. That's what I want you to kind of focus on. Again, not testable, but this is just for your mind and how everything works. So they have pre and postsynaptic activity, and presynaptic wise, they're blocking that calcium influx, so then therefore it is decreasing the excitability of that neuron from that stimulus that occurred, or that stimuli. And then remember when we talked about descending, how that was inhibitory? So what we're trying to do, once it goes up our ascending and it comes back down for us to modulate what that pain is, it's trying to lessen what we feel as pain. So you see how it activates the descending inhibitory pathways that modulate that transmission down the spinal cord back for us to say, okay, ouch, that hurt, or minimize how much of that effect we're getting, so that it's not as painful to us. Here are different types of receptors. This is very important for you to know because depending on the medication, some of them will be hitting different types of receptors, which explain why you have certain types of side effects, okay? So know this slide, even though this isn't one of our beginning slides. So your mu receptor, you see your M1 is more so dealing with the analgesia. When you have M2, that's more dealing with like your side effects of the medications of our opioids. So think of M2 being more so like if you saw toxicity or any type of overdose. And honestly, with these, you don't have to necessarily have toxicity to get a lot of these effects that you see there. So respiratory depression, the GI motility, all of those things that we're going to talk about a little bit later. You can see where they're at. I'm just wanting you to kind of focus on the main one that we will target, and the main one that we'll talk about is the mu receptor. There's also delta that happens, and you have your kappa. Your kappa is more, it does provide analgesic relief, but it also has psychotomimetic effects, which is essentially a patient will take it and it's kind of like they're in a psychosis. Okay, so they will have where they feel dysphoria instead of euphoria. So they'll start having different types of like hallucinations and things, like a bad trip, essentially, if they hit that kappa receptor too much. Also, you'll see the patients have depression more, and they also become more like drug seekers. It becomes more of a behavioral type of issue that you start to have with these patients when you have something that's more selective for the kappa. So think of kappas as they're bad. Okay, kappas are not, they're no good. And then the delta, you get analgesic effects as well, and they're specifically looking at the enkephalin's neurotransmitter. Don't need to go that detailed into it. Just know you have your mu, your delta, your kappa. Your mu is the one that's more so for our analgesic effects that we get. They're in several different places. That's why you get a lot of those side effects that you have. One of the biggest ones that we'll talk about is your itching and your euphoria comes up a lot. And then with your kappa, just remember the fact that that is the bad side effects that you get when you're talking about those psychotomimetic effects. This might look a little familiar to you because y'all have talked about different agonists, partial agonists, and antagonists. And this kind of follows that same pattern of what you went through before. So you have a full agonist, or they can call them pure agonists. And this was one of the slides that I cleared up that we had there before. So I'll give you this warning beforehand. When you're looking at the word that says partial agonist, right? Partial agonist, some people will say is also being a mixed agonist, or something that is a mixed agonist and antagonist. Some people use them interchangeably, but they are not interchangeable, okay? So just understand what happens whenever I tell you the definition so that you can kind of see where things go and follow it how it is on here, okay? All right, so your full agonists, they have high affinity for your mu receptors, okay? So this is like a tight bond that they have formed, high affinity, and there's no ceiling effect when it comes to you having your full agonist. So what that means is that the higher the dose, the more relief that you're going to have, which also probably means the more side effects that you're going to get. So being very careful with these medications, which is why they're very addictive, because in how they say people are chasing a high, because as you continue to have these medications and expose your body to them, you develop that tolerance, and then you need more to get that same feeling. So there's like it's just a vicious cycle. And so they try to continue to chase that pain relief. So that's why you, as the PA, are going to make sure that you're bringing your patient in at least monthly if you have them on, and they're not a chronic pain patient, at least monthly to kind of check in with them, see what's going on, and make sure that you can start tapering them down. If it's something that's acute, it's going to sound like it's a little bit obsessive, but probably having them come in every week to see you to figure out where their pain is, and are they becoming more chronic or subacute instead of acute, okay? So our ceiling effect means that if you increase a dose, that the effectiveness of the medication does not increase. That is if something does have a ceiling effect. What we're saying with our full agonist is there is no ceiling effect, okay? So the higher the dose, you are getting more effectiveness, more relief. But remember, as you increase a dose, you are going to increase the side effects that you're going to experience with those medications, okay? They don't antagonize other full agonists. So if you gave one full agonist and another, you're giving additive effects. So you're going to increase, again, the side effects because there's no competition. They're doing the same thing, and because there's no ceiling effect. So the examples that we have are listed there. I'm not going to read them all to you, but those are your example for full agonists. So I'm not saying a curse word, I'm just giving you an acronym to kind of remember it. So FOC, like FOC, HIM, HM though, okay? So that you can be like, it's a full agonist, okay, F and F. Your partial agonist and your mixed agonist / antagonist are ones that they are going to stimulate your receptor, but they're not going to get that maximum effect that you would think that you would see, or that you would want to see, depending on what kind of pain level the patient has. So a partial agonist or a mixed agonist and antagonist. So think about it. If I'm giving something that is going to increase my effects, agonist, with an antagonist, That's why some people will use these words interchangeably, because it's like I'm getting a partial effect. One is activating while one is trying to inhibit. Okay? So our agonist part of it is trying to activate, while our antagonist part is trying to inhibit what's going on. So you see here that they do have their ceiling effect. So if you increase the dose, you're not getting more relief. You're just getting, again, more side effects. Okay? And then the mixed agonist can activate and block opioid receptor sites, are exactly what I was just telling you. So if you give it with a full agonist, you don't know in some of these medications how they're going to act. Like, is it going to give me more of its antagonistic side right now, or is it going to be an additive effect with that agonist that I gave? So you try not to ever give a partial agonist with a full agonist, or a partial agonist with another partial agonist. Okay? No? Because they have the same effect. So I'm using the words interchange. That's why it says partial agonist and mixed agonist / antagonist. Okay? So a partial agonist can just be an agonist, but it's like a weak agonist. Okay? So it's binding to the receptors, but it's not, it's like a weak, it's weakly bound. So you're not getting a maximum effect of that opioid receptor that you could get. When you see mixed agonist / antagonist, it is one medication that has antagonistic properties and agonistic properties in the same drug. So it could bind to your mu receptor and be an agonist, and that same drug could bind to another receptor and be an antagonist, another mu receptor and be an antagonist. So that's why it's saying you can't give it together, because you could just be blocking the agonistic effects with the antagonistic effects of the same medication. It's a mess. I got you. But just know that it exists. Read it a couple of times, and it'll make sense. And you can talk to me after too if you need to. So our examples of a partial agonist is going to be your buprenorphine and your tramadol. And then the other ones, your butorphanol, your nalbuphine, and your pentazocine are all what you would consider mixed agonist / antagonist. Okay? Just refer back to this to get a clear picture of like what's going on throughout us talking about it, because this is very confusing when you try to read up on it outside, which is why I spent too long doing this yesterday. I didn't go to sleep last night because I was like, I have to make this make sense. So just refer back to this slide, because every resource says it differently. And some of them will classify the same medication in a different way. And they will say, oh, it's a partial agonist, and then on the next page or on another resource, it will say that it's mixed. Okay? So this is just a picture of what we just went over. All right? A full agonist, you're going to get that full opioid effect, whereas a partial agonist or one of your mixed agonists, you're going to get that midline effect, and your antagonist is just simply like trying to stop that opioid effect that you're getting altogether. So it's going to antagonize your full agonist or your sometimes your partial agonist, and we'll go over that a little bit later. So looking at why they developed the partial agonist or the mixed agonist / antagonist is essentially to decrease what they felt like the side effects were, or the toxicity portion of opioids, while trying to get the analgesic effects out of it. They also use it to balance and to deter abuse in patients. So if someone is receiving an opioid agonist, that is why you're going to try to refrain from giving them a mix, because you don't know which effect you're going to get. Okay? When you're looking at your antagonist, you're competitively blocking that opioid from binding to that mu receptor, so you're not going to get the effect that you're wanting to. It is antagonizing, right, at that receptor. So if I'm blocking it and I'm sitting on this receptor, I'm like, you can't sit here, you can't sit here. You're not going to get that opioid effect because the antagonist is sitting on that receptor. Okay? So what's important there is that you see that there's no analgesic effect. It's just blocking you from getting your analgesic effects from your opioids. So this is just some quick terminology that you will see when we're talking about dosing our opioids. You have ATC or around the clock. That's just meaning that it's chronic administration of an opioid. Usually they could be on a drip, just around the clock they're getting it, or it could be something that is scheduled around the clock. So they have every 8 hours they're taking this, or they're on a basal type of drip. As needed or PRN dosing is exactly what it says. So they may have like an around the clock dosing, and they may have like some type of breakthrough pain, and then you give them a bolus dose or an immediate release medication on top of that long acting that they have to help them through that breakthrough pain until they get to their next dose that they have around the clock. Breakthrough pain dosing, I just kind of explained it in the as needed dosing, but essentially if they have a chronic pain or any type of pain and we're giving them a basal dose or a long acting opioid to control their pain, and they have some type of breakthrough pain and I need to give them a dose of medication, that's essentially what it is, which is almost the same thing as needed. And then your PCA or your patient controlled analgesia, this is what you see when they're in the hospital and they're in the bed and they have a little button in their hand and they can press the button and it will administer the medication through their pump. And then the pump has a lockout time on it. So after they press it, they will make that pump is set to not allow that patient to continuously just like dose themselves. Okay? So it'll have a lockout period on it. If you see that a patient is trying to continuously like dose themselves before they're still in their lockout period, that may mean that you need to increase their dose or that their pain is not well controlled. Okay? Your total daily dose, that's the total amount of drug that you receive in 24 hours or your patient has received in 24 hours. And your tolerance is just, you've been exposed to a medication and eventually what happens is that initial effect that you get from taking the medication ends up getting decreased over a longer period of time. And then the mechanism behind this is essentially like you've tired out those receptors, and so you have down regulation, so you don't have as many receptors for your medication to bind to. So you're not going to get as much of an effect because I don't have the receptor to receive that medication. So that's what the down regulation of opioid receptors means. And then the way that you notice that this is happening is eventually the duration of pain relief that patient is having will start to decrease, and you'll see that they're taking it more often. So if you're initially starting the patient on a pain medication and they're trying to take it a lot, that probably means that they're not controlled, not necessarily that they are tolerant. If they have been on it and you had them stable and they were like smooth sailing, and then all of a sudden now they're needing to increase their dose, that's tolerance. Okay, so if you were like, oh, they were taking it every 8 hours and now I see that they need it every 6 hours, or now I see that I'm increasing how much I'm giving them IR or PRN meds, maybe I need to go back and increase my basal dose because they're developing tolerance to it. Now, if your patient is no longer in a lot of pain, but they're just pressing their button, or they're calling you to tell you that they need more meds, that's for you to assess with the pain scales and all those other things that we have, and looking at the severity of what that injury was. Okay? And then just understanding, and this is very important as well, that tolerance doesn't develop the same for all of the side effects that you can experience when you're taking opioids. When you're talking about constipation and your respiratory depression, those will continue to happen throughout a patient being on opioids, and that's because of the receptors that they're binding to. Some of the other things, usually they will get used to it after a while, and we'll go over that in a little bit. So constipation and that respiratory depression, they're not going anywhere, okay? But tolerance to other things can occur. So you have what's called opioid-induced tolerance, and essentially what this is like, it's a decreased sensitivity in a situation where they shouldn't be as sensitive to that pain. So now we've caused them to have opioid-induced tolerance. A lot of times this can be like a mental thing that that patient is going through, and also the physiological, because of the fact that like I've been dulling or numbing them from that pain for a while. So now I have to get them back, I don't know how to say, like, get them used to what that stimulus normally feels like, again, without that medication numbing down that stimulus for them. So again, this one is also recognized by that decrease in the analgesia at first. You'll also see the behavior modification. That's the psychological part of it. So just watching out for that patient to make sure that you don't see that addictive behavior kind of starting to happen. But this is more so, again, decreased effects because of the downregulation of those receptors that they have. Your opioid-induced hyperalgesia, or OIH, is a paradoxical increase in pain. So the way that you treat this is you try to decrease the dose that they have of their opioid and see if that does a paradoxical reduction in pain for them. So you're just kind of trying to mess with the mind to say, like, okay, now that you're saying you're experiencing increased pain while you're on this opioid, if I decrease it, then your sensitivity that you have should also decrease as well, is the thought behind it. I have never seen this happen in real life. It would be interesting to see, because I don't know how the patient can tell you anything. There's no way for you to really know what's going on. So eventually what you're going to try to do is you're going to try to taper that patient off of the medication if they haven't been on it for a long time. So less than a couple of days, you can just discontinue the medication for them. Physical dependence, that's more of like, okay, now your body is needing this. And that's when you'll see like the patients go through withdrawal. You hear a lot of people who are addicted to drugs, they'll say like they feel sick or like dope sick. And that's what this feeling, that's what that is, the physical dependence of it, because now you've kind of rewired how things are working in your body. And so you need it to actually feel well. Your addiction, that's just the behavior pattern changing, right? So I underlined the key words for you. It's them trying to, like, at this point, they're craving it, they're drug seeking to make sure that they get the medication that they need to also feel better. So addiction and physical dependence sometimes kind of go hand in hand, because you want to feel better with that, where you have your physical dependence, you kind of get addicted to it because you're like, I need this to feel better. So then you are kind of craving it, even though you may not want it. Okay, and then your pseudo addiction, this is just under treatment. So this is kind of what we talked about before, where you may not have gotten that patient's pain under control. And so it looks like they're drug seeking, but they may not be drug seeking. It's just that we never got them where they needed to be in the first place. Okay, so that's why you see the pseudo addiction, and I underlined the under treatment for you. Okay, so in that situation, make sure that you do your pain scale, check on the patient. Hey, how are you doing with this? And again, subjective, right? So I don't know if you're telling me the truth or not, but if it's something that continues to happen over and over and over again, then you kind of got to look at your patient and say, okay, let's see if we need to look into pain management or something, because then it'll be outside of your scope. All right, opioid withdrawal. Not fun, very, very, very uncomfortable, but it's not something that will necessarily kill the patient. You just want to be nice, so this is why we taper them off of their medications, okay? It is very uncomfortable for them. So when we abruptly stop something, especially if they've been on it for a long time, that makes their withdrawal symptoms a lot worse. So the longer that they've been on a medication, the longer that you're going to need to taper them off, and we're going to talk about it more so at the end of the slide as to how you're going to taper them off, the percentage that you'll need to taper them off of every month. We'll go over all of that. It gets very, very complicated. So pay attention to your patient. Also let them know what withdrawal feels like, so that they're not thinking that they're going crazy, or that they start to go against what you're telling them to do, and they're, because of the physical dependence, starting to dose themselves. Okay? So those onsets, I don't need you to remember those onsets. Just know that after they stop taking a medication, if they do not taper off of those medications, they can hit some withdrawal symptoms. You can see the symptoms over here. He has diarrhea, he's throwing up, it's just coming out everywhere. Every hole that he has, he's not feeling well at all. A lot of them will feel very tired, but then when they sleep, they feel agitated. Like it's not comfortable. Again, they're not going to die, but a lot of people, this is why it's hard for them to get off of the opioids, because they don't like this feeling whenever they're coming down. Here are all of our adverse effects that you can see whenever we're talking about our opioids. So our big one that we have is our respiratory depression. This is the most serious side effect that we have, and this is the most deadly one that we have. When you have a pregnant mom, or when you have a mother who is breastfeeding, it's also very important for you to watch out with the doses that you're giving them, because there's cases where all of the opioids, for the most part, pass through breast milk. And so you have some cases where patients were feeding their babies and their babies passed away from an overdose because they were getting the opioids through the breast milk, and the babies ended up having respiratory depression. So something for you to make sure that, yes, you have that mother and you're treating the patient, but if you have a mother who is breastfeeding, you need to make sure that what you're doing is also safe for the baby, or it's something that is very like a PRN thing and they're not on a long-term dose. If they are, you need to find alternatives for feeding for the baby, or see if the mom is willing to step down to, we'll get there, but if they don't step down to something else. We already talked about tolerance, CNS excitation, right? So you can have euphoria. When do you have dysphoria? Which receptor? Kappa, right? So that's just showing you these things here, and also the possibility of you having seizures, nausea, vomiting. See that all the time. Constipation, because of the fact that opioids decrease the motility in the GI from the receptors being there. That's why you see the constipation. They have medications that treat it. Also, we can try to prophylactically treat a patient with like a stool softener and a laxative. Sometimes it works. If it doesn't work, then we have other medications that we would go to when we're dealing with trying to treat them for their constipation. But a big thing with the constipation is making sure that your patients are very well hydrated, and that they have fiber in their diet, and that they are eating well when they are taking these medications, because a lot of times the food will decrease the nausea and vomiting, and it will also decrease a lot of the GI side effects that they're getting as well. Increased histamine release. It sucks, okay? It is the most uncomfortable thing if you have the histamine relief. So the biggest one that you'll see patients get is the pruritus that comes along, and they are itching like really, really bad. It happens to me, which is why I hate it, and I'm glad I'm not having any more babies. It's the worst thing, and I don't know how to describe it, but like you're itching to where you scratching your skin off. It feels like there's like an itch that you just can't get to. So if you're having a patient that you're going to put on an opioid, just make sure that you have an order put in for them, just in case you get caught up doing something else, especially with morphine. Morphine is the highest offender with this, as well as the seizures. So, well, seizures is more meperidine. But with your morphine, that is your highest offender for your itching, okay? So being nice, just put that on your order set for them whenever you're giving them one of these opioids. You have your meiosis, and then we already talked about, and the CNS depression, right? That's why we tell people not to drive. They're gonna get drowsy. Don't operate heavy machinery. It's like on the label of the prescription. Some patients, especially our chronic pain patients, if they're trying to live a regular life, they're not able to sometimes avoid doing those things. But like I said, over time, the CNS depression is one of those things that they kind of develop tolerance to. What are the two that they don't develop the tolerance to?
Constipation
and constipation and respiratory. All right, so our toxicity symptoms. You will have patients who are going to be pushed into toxicity, right? It happens. Patients who overdose on opioids, they will come in and they will present being confused, agitated. You'll see a lot of them will say that they're like essentially hallucinating, and then you can see some respiratory depression. Don't automatically assume that the patient is abusing and that they did it on purpose. Some patients, they are in pain and they're just trying to relieve their pain, and they will take more. They're like, oh, it said take 3 or 1 every 8 hours. That's 3 in a day, but I just took all 3 of them together. Like, some people will do things like that because, like, I just didn't feel well, or it didn't work for me in 5 minutes. Like, I took another one and I took another one. So don't automatically think abuse when people come in. A lot of the times you're going to be like, that was stupid. Like, why would you think that? Like, it says this for a reason. They are not in the medical profession like you are. Okay? So the treatment for that, we'll hold the dose for these patients, and we can also give our naloxone, which is our antagonist that we saw on our chart. So we're trying to block the effects of the opioids that we have in the system for that patient at that point to decrease the effects of their overdose that they're experiencing. So true opioid allergy versus a pseudo allergy. True opioid allergy is IgE and T cell mediated. So what that will mean is that that patient is probably not going to experience on their first time that they've had it. They're going to have some type of re-exposure to this medication. So these are going to be usually your patients that they've been on it before, or they ran into opium in the wild, right? And they had some type of reaction to it. Less than 2% of the population have a true opioid allergy. Most people have a pseudo allergy, which is like histamine release. This can happen on the first time that you give a patient a dose, okay? So opioid allergy, you need to have, you're gonna have to have more than 1 dose for you to have that mediated response, and it's very rare. And there are more severe effects that you'll have when you're having the true opioid allergy. It's life-threatening, okay? They're having like edema, bronchospasms, like they're not able to breathe. You'll see like they're like super swollen, red. That's how that presents. Whereas when you have your pseudo allergy, it's more so like a rash. They're itching, they might be sweating, their blood pressure is going to drop a little bit, but it's not as life-threatening as you would see with your true opioid allergy. And again, we talked about morphine being one of the ones that had the highest itching. So that's one of the ones who has the highest pseudo allergy. This is just a summary chart, so I'm not going to read it, of essentially what we've talked about before. The only thing that I didn't talk to you about was due to the respiratory depression in patients who could have head injuries, meaning they could possibly already have some type of respiratory depression. You would want to avoid opioids if you can, because it can increase the intracranial pressure in those patients. We talked about the pregnancy, pulmonary. We talked about the fact that you can get those, if they overdose, you can end up with, or if they have an allergy, sorry, you can end up with the bronchospasm, but also the fact that you have respiratory depression. So if I'm already having trouble breathing, I'm not going to give them something that's going to compound them breathing. Hepatic or renal function, that's just depending on how they're metabolized and excreted. And then if they have endocrine disease, it can increase the duration of action of that opioid in those patients. So we want to avoid that if we can. The question here, what is the answer? Does anybody see what's going on? E? Okay. Why did you pick E? Yes. If they're overdosing, they need an antagonist. Any questions on it? All right, getting into the agents. So here are the different classes of agents that you have. I'm debating, so I will have it for you by the review on if I want you to know what the classes are. So by tomorrow, I will let you know. No, you don't want us to know. I will let you know. It's not really something that we use because they're all pure opioid agonists. So I'm just going to answer myself now. Just know that they're pure opioid agonists, okay? The further classification of that, I don't need y'all to know that because nobody refers to them this way, okay? So your phenanthrines, those are your medications that you have listed there. We use morphine quite a bit, and then also your hydrocodone and codeine. And understanding that if you have these medications and you have somebody who has some type of allergy to it, whether it is a true allergy or the pseudo-allergy, that there is a probability that they can have cross-reactivity to it. Okay, so what you would do in that situation is switch them to a different class instead of switching them to another medication within the same class. Okay? Your phenylpipridines, those, the one that you see all the time is fentanyl, of course, cross reactivity low. And then your diphenylheptanes, your methadone is the one that's there, low cross reactivity as well with that one. So your partial agonists, we already talked about these on that other table that I showed you. So these are just what are classified as other opioid agents, right? So that first slide that we just looked at were your pure agonists. So do you get a partial response or a full response with that affinity to the mu receptor? Full, okay? These are like partial or mixed, depending on which one, or an antagonist. Okay, so your partial listed there, your mixed there again. We talked about this. Antagonists are also there. And then your, what is interesting about opioids is their antitussive effects. I will never again, ever take codeine in my life. I had the worst cough. My doctor was like, well, this has been going on for 3 weeks. We'll give you some codeine. The dreams are the worst dreams ever. I woke up and I was exhausted, and they are super vivid dreams, and you feel like you're in a daze and like have this crazy hangover. The problem was after I took it that one time, my cough started coming back because I was like, I'm not taking it again. Underlying issue is never going to be fixed by you doing that. You're just decreasing the reflex that you're having. So you still need to figure out what the underlying condition is for that patient having that cough, especially if they're having it for a long period of time. Also, make sure that you're not giving them a lot of codeine. Okay, people like codeine. People like the way codeine makes them feel. They pour it in their drinks. Yeah. they do things with it, okay? So it sounds crazy, right? But people do crazy things, and then they need more, right? And then we have this ceiling effect where you can continue to chase that all you want, but now all you're doing is increasing your side effects, and you see a lot of these people who do this who end up with respiratory depression, some type of seizures and other crazy things that's going on, falling off stage while they're performing, okay? This is what happens. Don't give a lot of codeine, all right? Dextromethorphan is very good as well for coughs. In our pharmacy, when I worked at Walgreens, we had it behind the counter, but it wasn't over the counter. So a patient could come up to the counter and say, I would like this medication, and we would give it to them. We didn't just leave it out front. As you see, it is a OTC codeine derivative, okay? So we had that behind the counter for us for the most part to make sure that people weren't doing crazy things. And then when you're talking about naloxone, one thing that I want to point out when it comes to naloxone, you need to make sure that the patient, when you're talking about it, they're having an opioid, or it's a pure opioid that you're giving naloxone for. Yes, you can give naloxone for an overdose in someone who has like a mixed agonist or a partial opioid agonist, but it doesn't necessarily mean that it's going to fully reverse those effects. So in a pure opioid agonist, so any of these, will get a full reversal. It may take several doses depending on how much that patient had. You may have to administer it more than once, but you will get a reversal. In this situation, because we don't know what receptors the medication has bound to, is it all mu, is it kappa, did they bind to some delta? That will be that mixed bag to where you can have some reversal but not complete reversal, okay? So the only way that you're going to get full reversal with your naloxone is which class? Pure, okay? All right, epinephrines. I don't need you to know this, okay? But the idea of this slide is just showing you that you have your 384 and your 2D6 that are your main CYPs that are metabolizing our pain meds, okay? Some of them are prodrugs. We will go through the ones that are prodrugs. So if you are inhibiting those CYPs, it's not going to work, okay? All right, morphine. Morpheus is up there at the top. Okay, morphine is a good drug to use. It is a C2, so highly controlled medication, very good for pain. As you see, it has high affinity for our M1 and our M2. Seeing that you have that M2 high affinity as well, that means that you're going to be looking out for those side effects because they're likely to happen. So this is considered a strong agonist. You see that it can also weakly bind to your delta and your kappa, but what we're looking at more so here is the fact that it's a strong M1 and M2. So pain, when we're using it, of course, that's why we're using it for pain. There are several different formulations. You have your PO, you have your IV, your IM, rectally, they can give it, that's your PR. Your pharmacokinetics. So the thing with this one is the least lipophilic, so that means that only a small amount of it is going to cross your blood-brain barrier, which means that you should have less euphoria. Looking at this, though, you can also see that it can cross the placenta. So again, worrying about the fetus is going to be something that we are concerned with in this patient population. The metabolites that we get, you have your M3 and your M6. The M3 is the one that has no actual activity. All it's doing is causing the side effects that we see when we're talking about morphine, whereas you have your M6 is giving the activity of what you're expecting to see from your morphine. So of course, if I have renal impairment, I'm going to have some accumulation. Looking at this, you see that heroin and codeine are metabolized to your morphine, okay? So that would mean that codeine is a prodrug to morphine in a way, when you see that something can be metabolized to something else, or it has an active metabolite. Okay, so you can get a longer duration of action. You have to see what's going on with that patient and how they are processing the codeine. Because then you're going to get hit with those morphine, the morphine side effects as well, or the metabolites for the codeine. I need you to know all of that. Adverse effects, we talked about the increasing of the intracranial ICP whenever, due to the respiratory depression that you have, nausea, vomiting, itching. I told you this is one of the main ones that cause itching. So that's what I was telling you. Be nice to your patient. Have that order on hand. You can pre-treat if you would like to pre-treat for the patient. You can also just ask the patient, have they ever had a reaction to it, and see what they say. And that can also guide you on if you want to pre-treat that patient or not. It won't hurt. It'll just make them a little drowsy, which is already going to happen anyway. You can also get that hypotension with this medication, so just watching out for that, and your urinary retention and your constipation due to the fact that those new receptors are in the GI area. Go ahead. Well, let me tell you one more thing about this real quick before we do our break. Morphine is kind of like our prototype that we are basing everything off of when you're trying to switch from one opioid to another. So when we start talking about our calculations, you'll have your MMEs or your morphine milligram equivalents. That's what we are going to use to say, hey, what dose should I be giving my patient if I'm switching from, let's say, hydrocodone to morphine or hydrocodone to meperidine or what have you. So we'll get to that, but just understand that the MMEs are essentially used to gauge the overdose potential that somebody could have from an opioid when they're switching from one class to another. Go ahead and take your break, and we'll start back here with our mu receptor agonist that is derived from morphine. Okay, it's not metabolized like from morphine. Okay, it's derived from it. So it's like, oh, I like how you look, morphine. I like your style. Let me make me some hydromorphone. That's kind of what happened with it. So what they were trying to do was they wanted to have something that had better PO absorption, more fat soluble than their morphine. So that's how we ended up with our hydromorphone. You see it's more potent, and you see that it also crosses the blood-brain barrier, which our morphine did not. PLIV formulation. This is your next step up if they have moderate to severe pain and they aren't responding to our non-opioids or our NSAIDs that we've tried to treat them with. Okay. What's different about this medication is you see that extended release formulation has what's called a risk evaluation and mitigation strategy, REMS for short. With REMS, the pharmacy has to register, the patient has to register, and the doctor has to register. And there's a couple of meds that fall under these categories so that you can make sure that you are mitigating the risk from that patient taking that medication. It's making sure that they are acknowledging every month that they pick up this medication, that they know that they are taking a risk by taking the medication, okay? There's some other medications that, I don't know if anybody's taking Accutane. Accutane is one of those meds that's also a part of REMS as well. So every 2 years, everybody has to refresh their credentials, specifically the doctor and the pharmacy. But every time that a bill is picked up, they have to do the REMS. And then you'll get an authorization number. Well, the pharmacy gets an authorization number, and they write it for the patient to be able to pick up that medication. They keep track of those REMS numbers every time someone comes to pick up their meds. So it's just something for you to know that if you're doing hydromorphone, usually this is going to be when you're dealing with your PO, you're going to have to register for REMS. If you're an MTF, you'll be fine. We have it. Your hydrocodone, another C2 medication. This one is one of the ones that you're going to see that is usually in combination with your Tylenol. Very common for our patients to be prescribed this orally. It is a moderate mu receptor agonist, and one of the ones that are metabolized to hydromorphone. So I did another little arrow thing for you to kind of remember that. Again, if they're not responding, this is our step up, and you can also use it for cough in patients. With our combination medications, you see that you can, it's more commonly combined with Tylenol versus ibuprofen, but it can have either or. When you are dealing with this, make sure that you're getting the patient's history for what they are also taking over the counter. Because a lot of people don't know that hydrocodone/APAP means Tylenol. And they will also take their Tylenol over the counter, and we already know what our Tylenol does, right? We have our NAPQI, all of that good stuff. So you don't want them to get toxic, so make sure that you are talking to them about the fact that there's Tylenol in this medication that I'm giving you, there's ibuprofen in this medication that I'm giving you, you don't have to take more. If your pain isn't controlled, please come back and talk to me. So morphine, what did morphine have a high affinity for? Which mu receptor? Both. Is one better than the other? More affinity for M1 over M2, or is it equal? Equal. Okay. Oxycodone, another C2. Okay. C2s, this makes sense because they're highly addictive, right? Our opioids are highly addictive, tolerance and all that stuff that's developing. So mu receptor agonist, low binding affinity when it comes to this one. You have your noroxycodone and your oxymorphone, which are both active metabolites, so thinking about the duration when it comes to that is very important. And if you have any renal issues, making sure that you are adjusting the dose in the patient, or if you need to and it's that bad, not giving it to them at all. moderate to severe pain, okay? And then our formulations that we have are PO. When you think about your oxycodone extended release, I used to get confused with this all the time. The brand name is OxyContin, so it continues. Thinking about it that way for your ER formulation. Because some people will just refer to this as OxyContin because they are trying to differentiate between the duration of actions of the medication. Okay? So Contin continues. With your OxyContin, you have an abuse deterrent formulation to where if a patient tries to crush it, it'll make it either to where it turns into like a gummy, mushy, not something that they would want to inject or snort, or they have to where it will make them just vomit, like it is not pleasant. I had one of my patients, she came in and she's like, I tried, ma'am, and I was like, please don't tell me this, I don't want to hear this story. And she was like, it's so weird, how did they get so smart and know how to do it? Now, this is very controversial though, because they're figuring out ways to get around the deterrents that they're putting now in the opioids. So they're finding ways to still be able to extract the opioid from the deterrent that will make it either like a gummy or that is an antagonist so that they don't get that opioid effect. So people are smart and they put it on YouTube and things and patients go and look it up. And my patient told me, she said, I tried it and it didn't work. I was like, I don't want to fill your prescription. And I didn't fill her prescription. All right, codeine. Depending on how you give the codeine, you see that it can fall into different categories, C2, C3, C5. The formulation is why you see the difference in the abuse potential of the medication, okay? So again, it's a prodrug, we talked about that. It's metabolized to our morphine. And then thinking about using this mild to moderate pain, also we talked about the fact that we can use it for a cough. What is very important here, and I read a case about this one, is looking at your ultra rapid 2D6 metabolizers. The reason why this is very important is because they're going to convert that codeine more quickly to morphine. Okay, so the chances of them getting those side effects and that respiratory depression is going to be largely increased. This is another case where a mom was taking this. She was a rapid metabolizer, and I believe the baby was also a rapid metabolizer. So the little bit that was passing into the baby's system ended up making the baby overdose, and the baby passed away. And when they did like the autopsy, they found out that the baby was also a ultra rapid metabolizer as well. So if you can give low doses with our opioids, that is always what we are trying to do, okay? Because you don't know if somebody is a rapid metabolizer or not, and yes, you can test for it, but usually by the time that you think to test for it, it's already too late. So your black box warning you see is the death related to the ultra rapid metabolism. If you have children that are under the age of 12, we are not giving it to them at all. If they are between the ages of 12 and 18 and they had a tonsillectomy or their adenoids removed, we are also not going to give it to them because of the risk of that, the respiratory depression. So 12 to 17, tonsils, adenoids, less than 12, no. Both of those are no categories, so contraindicated. You can write your CI next to that. Because I'm going to tell you. We already talked about that. Depending on what it's combined with as well as what the formulation is how you'll get the different C2, 3, or 5. I don't need you to know what formulation goes with what one, okay? Looking at the Tylenol with codeine, your number 3 or number 4 tablets, the difference there is the amount of codeine that is in them. So 30 milligrams is in the Tylenol number 3 and 40 milligrams is in Tylenol number 4. If somebody has asthma, we're not going to give it to them because of the fact that it has what's called a metabisulfite in there, and it can cause a bronchospasm in those patients. So contraindicated, do not use that, just that particular, your T3 or your T4. Okay? Did it change for y'all? Okay, computer. All right. Our mixed agonists, antagonists, or our partial agonists, remember we're using all those words simultaneously or interchangeably. We already talked about how they work. Looking at your adverse effects, they're similar to what you would always see. Because of that mixed activity that you have, some of these bind to that kappa receptor, so that's why you see your psychotomimetic response there. Also, withdrawal, we're going to see that with all of our opioids as well. The ceiling effect, we talked about that because they're partial. Do you have the ceiling effect with your pure agonists? No. Okay. Lower abuse potential when we're talking about these, and then just looking at the fact that if they are on a opioid, so one of our pure agonists, and we give them one of these mixed, we could now be getting that patient uncontrolled, because if it is exhibiting or binding to the receptor and with its antagonistic properties, now you're blocking your agonist from working. So that is why that statement says can precipitate withdrawal and increase pain in patients receiving an opioid agonist. Because if I have a mixed one, which has antagonistic properties, I am antagonizing that opioid, so now I'm getting less pain relief, and I'm probably going to have withdrawals because I'm not having that opioid hit those receptors how it was. So if you have to give them together, you may have to increase the dose of your agonist to overcome that effect, but that's not desirable because, again, as you increase those doses, you're getting more side effects, okay? So avoid that combination together. We talked about the fact that naloxone may not reverse something that is a mixed or a partial agonist because we don't know how it is bound. Is it in its agonist nature or is it in its antagonistic nature? So one of our meds that we're going to look at is our buprenorphine partial agonist, and this one is used a lot whenever you're talking about detox for patients who are on opioids. They have a lot of buprenorphine, and there were a lot of clinics previously, but now since they have changed the requirements for certain providers being able to have a detox center, now anybody, because of the crisis, anybody now can have and be able to prescribe, the buprenorphine without any type of waiver. There's just some training that they have to do and renew every now and then, and they're allowed to prescribe. The idea is that we don't want patients to overdose, so if they're going to come to you, whoever their PA is or their PCM is, we would prefer them to do that and get the buprenorphine versus waiting to get to a clinic and someone who has this specialized training. So before they had to have like an identifier with their DEA number, and now they don't have to have that. They just have to have a regular DEA number to be able to prescribe it. It is a control, so they still have to have a DEA number, be registered for a DEA number. So that is what all of that is saying. When you look at the reversal of this medication, again, I just want to hit this home for the last time. Naloxone will not reverse the actions of your buprenorphine because of the fact that it falls in that partial or mixed category. The only thing that your naloxone is helping with are your pure agonists. Pregnancy, again, watching out for that, has a long half-life, so not good for the baby. Your phenylpipridines, I don't know if you can see that little bitty drop right there of white powder next to that penny. That is a lethal dose of fentanyl. It doesn't take a lot. So that's why you see a lot of the times cops, whenever they're arresting people or they're trying to do drug busts, if they think that somebody has fentanyl, they usually have their gloves on, because that's all it takes for them to go into some type of respiratory depression, and they can die from it, and they can have an overdose just from touching it and it getting absorbed through their skin. So this is something that people need to be very careful with. A lot of people abuse this. I had patients who would come and they would get the patches and they were chewing the patches to get high instead of like putting it on their skin. So people will find ways once they are addicted to these medications. So just pay attention to your patients, listen to what they're saying, and if they end up being in a category where you need to help them, that's your job, to help them. Your fentanyl derivatives that you have, sufentanil, alfentanil, and your remifentanil, which we'll talk about once we get in here. So your meperidine, mu and delta receptor agonist, so that's why this is falling in our mix. Strong agonist with our anticholinergic. Anticholinergic is a dry or wet? Drying things up. PLIMIV routes, and this is for your acute dosing only with our moderate to severe pain. What's also neat about this medication is that it has anti-shivering properties, or like it can prevent rigors, which is like when people have that sudden cold feeling and they're shivering. You can give them the meperidine to kind of help them. Some patients will be like that post-op. Also, some patients are like that when they have a very high pain level. They'll start to shiver as well, and this kind of helps calm them down. It's helping with their pain as well. C2 medication, you see we're avoiding it in our renal insufficiency again. That's all of our opioids. We're watching out for it to see how it's metabolized. Again, I don't need you to know the specific SIPs that are metabolizing them, but just know that it occurs. This one is one of the first ones that we see that it has the hepatic metabolism as well. So looking at the fact that if you give it oral, so less effective by our oral route than if you were to give it IV, that's because of our bioavailability rate of having to go through that first pass effect and all that good stuff. And the fact that it has extensive metabolism through the liver whenever it gets there. Metabolites, you see you have your normeperidine, which is neurotoxic. This is the problem with our meperidine. It has a long half-life. You see it can be up to 30 hours, and you have that excitability that comes, the CNS excitability that will come whenever you're dealing with the neurotoxicity. This is due to the fact that they have some impaired renal clearance, and now this metabolite has accumulated and the serum concentration has gone up, and so we have the toxicity, you have your CNS excitability. Their heart rate will decrease. Looking on the other side, you see that if a patient takes any MAOI, that they shouldn't be taking it with meperidine due to the fact that they can have those fatal reactions that are occurring whenever they're giving them, because the serotonin breakdown will be inhibited with the MAOIs, and you're also getting the same effect when you're talking about the meperidine. So that's why you don't give those two together, and it's contraindicated. Caution in our patients who have hepatic impairment, and if they're older, our older patients with any of our opioids, we need to be very careful when we're talking about that. We already said our adverse effects were anticholinergic effects. And then looking at the fact that you have hypotension, which was one of those things that we saw when we looked at the adverse effects of all of our opioids in general. Another unique side effect when it comes to this is our seizures that you have when you're talking about your meperidine, okay? So this is, when we looked at that adverse side effect chart, this is one of the highest figures that you have for your seizures. Our withdrawal symptom may be severe whenever you're decreasing them from their meperidine. So usually, another thing I wanted to point out, when you're having them take, if they have an MAOI that they're taking and you need to give them meperidine, or you know that they have a surgery that's scheduled and you want to use meperidine, there needs to be a 14-day washout between those two medications. Okay. Fentanyl is your friend. C2 medication, mu receptor agonist, okay? Lipophilic So will it cross the blood-brain barrier? Yes. All right. Y'all so smart. More potent than our morphine, and then we're going to look at the different formulations that we have and kind of break that down so that you can understand the duration of action, the onset of action with the derivatives of fentanyl as well. Moderate to severe pain, you have your transdermal. For your severe chronic pain, these are going to usually be your cancer patients that are taking it. Do not give these to anyone who is an acute patient, only chronic pain. They also have the lollipops. Have anybody used the lollipops before on any other patient? Yeah? Okay. I haven't been fortunate enough to see them, but it's a go-to. So as you see in your TCCC, your go-to when it comes to your lollipops. And then looking at your IV formulations, just being aware of your patient and their consciousness, okay? Watching what they're doing. Your lollipop, when it's talking about the buccal. So these are patients that are usually going to be, you can use it in acute pain. It's not ideal, like stateside wise of using it for acute pain. But if they're tolerant to their around-the-clock pain management, then you'll want to give them this to kind of help with that breakthrough pain. So it's more of like a PRN type of medication for them. Transdermal, we talked about that. They'll put the patch on, they leave it on for 3 days. Some patients will say, depending on the brand, that they'll fall off. So if you have patients who come back and they're like, oh, they fell off, that's probably true, depending on what the DOD gets at that time. But you can tell them that they can put the athletic tape around the edges and just change it so that it can stay on for them. So your TERF, or your transmucosal immediate release fentanyl, is only for your lollipop, and it's just the REMS program specifically for that. We already talked about this, remembering that the patient, the doctor, and the pharmacy all have to register for that REMS program. Here are our derivatives that we have. So your sufentanil, your remifentanil, and your alfentanil. You will use these based on what you're doing, and I didn't get that detailed into this because we don't do all this, but like sometimes when you're intubating and different things like that, you'll use different ones of these. So your sufentanil, slightly slower onset than your fentanyl that you have, but the duration of the action is about the same. When you're looking at the onset for this, it is like, it's kind of minor as to the fact that it's slower. So your sufentanil is almost the same, okay? So slightly slower, S and S. Your remifentanil, R and R for rapid. Remifentanil, the rapid one, and it also has the shortest duration of action. So quick on, quick off. So if you want to be able to wake someone up and kind of figure out what's going on, but you want to knock them out, this is a good one to have because it has a quick onset, short duration of action. You can put them out for a little bit, wake them up, check in with them, put them out again if you need to. Very good medication. And alfentanil, rapid onset, but also a short duration of action. So Remi is your rapid, your most rapid, and your shortest duration. Your sufentanil, slightly slower with a similar duration. And your alfentanil, rapid onset with a shorter duration. And then all of these, you see they don't accumulate when they're infused how our fentanyl did. Your diphenylheptanes. So the one thing that we have here is our methadone. They were real clever, right, with their brand name, Methadose. Like, oh, y'all thought about that? Not really. So your C2, you see that it's hitting all of your receptors, mu, kappa, and your delta. Antagonist at the NMDA receptor. So essentially, this is why you see some people try to use this when it comes to neuropathic pain over other opioids. But again, this is not one that we would go to initially. We're going to try to use our adjuncts that we have, our gabapentin, our pregabalin, before we use these. And they also don't produce as much, they also don't produce as much euphoria that you see with your other opioids, okay? So looking at this is very unique, and they will also use this a lot in patients who have chronic pain. You also see it with our opioid use disorder. With this, the treatment is going to be short term. So if you're treating a patient who has opioid use disorder, you're going to be treating them for about 5 to 14 days. There's a whole taper that you would use whenever you're dealing with it. I don't need you to know all of that, but just knowing that if you are going to have them on it for opioid use disorder, right, so to get them off of the opioid, you then need to taper them once they're on this. So then you're going to have to taper them off of this as well. All right? So you're kind of replacing one evil with another in the sense that you still have to taper it, but this one just doesn't give them that same high that they're getting from the opioid. So that's why we're using it in our opioid use disorder. I'll go over the conversions when we get there, but essentially trying to convert methadone to other opioids, like to get an MME, is super variable. So we don't really do it, and I won't teach you that. Go to your pain management specialist if that's something that you have to do. A lot of resources now won't even give you the MME equivalent in the table for you to calculate it because it's so variable. All right, our miscellaneous opioids that we have are tramadol, okay, C4 medication, partial mu, and you see that it also has your serotonin and norepinephrine reuptake inhibitor. Oral medication, moderate to severe pain, is good medication to use. Again, this one also has where you can have your ultra rapid metabolizers leading to that respiratory depression. If you're giving it with other medications who are going to affect your serotonin levels, that's why you see the increased risk of your serotonin syndrome. So watch out with those medications. And then you have your side effects, your CNS effects, specifically looking at your seizures. And again, when you're giving it with other medications that have that serotonergic action with them. So will this medication respond fully to naloxone? No. Okay. Our opioid antagonist, naloxone. All right, so mu receptor antagonists that we have, we're using this to combat the effects that we would have with our opioids, okay? So shorter acting rescue medication, you spray it up the patient's nose whenever you see that they go down, because that's how it happens. When you give this by mouth, okay, so you have your two formulations. You have your spray, which we're using to treat our patients who have the opiate overdose, and then you have where you're taking it orally, that is for constipation. So you're trying to get them moving. So that's what it's saying, use orally for opioid-induced constipation. Okay, so if you ever see it orally, ask, because sometimes people really do pick the wrong one. And they're meaning to send the patient home with naloxone spray as like their rescue. If you have a patient who has like higher doses or higher MMEs, you want to also co-prescribe naloxone as a preventative measure for them. And then we counsel them when they come to the pharmacy to tell them how to use the naloxone just in case they do have an overdose. This is not just for people who you think are addicts. Like, this is for people who are on chronic pain management, or if they have higher doses of opioids, you want them to have this. After you give a dose of your naloxone, I do want you to know that you can repeat that dose in 2 to 5 minutes if they didn't respond to it. What else do I want you to do with this? Sometimes your patients, they will wake up So that's how you'll know that, oh, this was probably an opioid, but they'll crash again, which means they probably had a lot of it. Okay, like they had a major overdose. So that's why you're giving more than one, and most of the time in these boxes, they come with 2 in the box. This is essentially what I was telling you. Any patient that you're going to give opioids to that are outpatients, just go ahead and prescribe them the naloxone. The pharmacy also screens for this as well. It's easier for us if you guys just write the prescription when you send them over. Anybody that has over 50, greater than or equal to, 50 MMEs are going to be the ones who are going to be, you're going to be giving this to as a rescue, just in case they need it. What else do I need you to know about this? That's the main thing. If they have opioids over 50, make sure that you're giving them some naloxone. They don't have to be completely out before you give it. If you see that they're starting to having trouble breathing, it's better for you to administer it early versus late, okay? So if you see that they're starting to have that shallow breathing, they're starting to lose their color, go ahead and give them their naloxone. And then call the ambulance. Because after you run out of that second dose, if they crash again, then that's it. You're not going to be able to bring them back. So call 911, give them their doses. Okay, I haven't really seen or dispensed Evzio or the injectable formulation of Narcan, but this is just an injectable that you have available. Same exact things that's going on. Nothing here that I really need you to know besides what I already told you, giving it every 2 to 5 minutes. And then if it was a partial agonist, same thing that we already been talking about. It may not respond. You may need to give several doses before you get a response from that patient. The left panel, I don't need you to know that, so you can cross that out. If they're pregnant, just know you can still give them the naloxone, okay? This is a case that I want you guys to read through, and let me know what you get, please. Actually, I'm going to need to tell you this one because I don't know if I said this out loud because I don't remember saying it out loud. So the answer is D. What's the other medication that we talked about that causes seizures? It starts with an M, but it's not a M. Meperidine, yes. Okay, so meperidine and our tramadol. Meperidine, what was the other thing that was kind of different that we could use to treat with meperidine? If they had that, or whenever they were, yeah, the rigor. All right, pain management. We almost done, y'all. Can't believe we got through this. Okay, you will hear a lot of people talking about multimodal pain management. What that means is that you are going to start with the lowest thing that you can give them before you are trying to go to an opioid. So sometimes that may mean I came into you and I told you something hurt and you were like, oh, that's nice, go to physical therapy. Or try these exercises on your own at home. Then you could go up to my non-opioid medications and say, here, try this Tylenol, try this NSAID. If I'm still coming back to you, then you can say, all right, here is this opioid that you have, starting with your weak before you get to your strong medications, right? Which is at the top of the ladder. Sometimes, and why it says multimodal, is you will mix some of these things together. With our patients who have pain, most of the time, if they're able to move, we want them to also be doing some type of physical therapy because we're trying to fix that underlying problem if we can. Some of these patients, there's nothing that we can do about it, and we're going to be treating them and they're chronic pain patients, okay? So again, looking at what's going on, just like you can go up the ladder, you can come back down the ladder. Okay, so we're checking in with our patient to frequently see if there's a way for us to taper them off or de-escalate our therapy. If I gave them an NSAID with an opioid, can I start to pull my opioid, taper my opioid off? Can I just leave them on and manage their pain now because I'm a week out with just my NSAID? That's what multimodal pain management is. You will hear it a lot, especially if you're in the hospital. So looking at our treatment, there were CDC guidelines that came out, and they have these 12 steps or 12 key points of things that you should try to look at whenever you're prescribing your opioids. I'm not going to make you guys remember every single one. I just want you to remember, like, I don't need you to know that number 1 does this, number 2 does this. We're going to talk through it, and it all makes sense because we've been talking about it, but I don't need you to memorize it. Just remember what I'm going to say, okay? So your acute, less than 1 month. Subacute, 1 to 3 months. Anything over 3 months is chronic, okay? So as you hear this when we're going through, these are kind of how they're categorizing acute, subacute, and chronic. Also, before you starting your opioids, we already talked about this. Assess your patient, see what's going on, see what goals they want. Also, let them know what's realistic. If you have to cut off my foot and I'm in pain and I just had surgery for you to amputate my foot, my goal for me to run is probably slim to none. Okay? So having realistic expectations with the patient on what's going on. Yes, we can motivate them. Yes, we can say like, oh, I'm going to try to get your pain under control, but we can't guarantee them that we're going to make phantom pain go away or that we're going to make their nerve pain go away. So don't ever promise anything. Just sit down with them to come to a shared agreement on how you're going to manage their pain and where you're going with their treatment. And then before starting therapy, again, risk versus benefits, all that good stuff is essentially there. It is your responsibility to check on the patient, just like it is the patient's responsibility to check in with you and let you know if those medications are working for them or not. So if you have the old version, this is completely different. So just please make sure that you're having the new version. So these are the 2022 CDC guidelines for prescribing opioids for chronic pain. They also discuss acute, subacute, and chronic pain in here. So why that title just says chronic pain, I don't know. But essentially what you're seeing here is that you want to start with your non-opioid, non-pharmacologic treatment before you move to opioids. When you get to opioids, you want to do the lowest dose first before you are increasing doses for those patients. You also want to make sure that you are checking in with them more frequently if it is an acute or a subacute injury that they have versus chronic. So if I have a person who has an acute, I'm probably going to limit how much I give them to maybe 3 to 4 days so that they can come back and so that I'm less likely going to have to taper them off of that medication. Okay? If it's chronic, checking in with them every month to kind of see what's going on. If they need anything, has their pain decreased any, can you start to slowly taper them, is going to be a good thing because the longer we leave those chronic patients on those opioids for a longer period of time, the longer the taper is. Like I'm talking about over months. If people have been on opioids for years, it can take you months or up to a year to taper a patient off of opioids. Okay? So essentially, that is what this is saying. If you increase to over 50, greater than or equal to 50 MMEs a day, then you're likely to have more side effects and respiratory depression, which we don't want to do. So that's whenever your risk will start to outweigh your benefits. So your key number that you're looking for is 50. Okay? What else from this page? If you can do your immediate release first before you do long-acting, that is also better, right? Because I'm minimizing your exposure to that opioid, so it makes sense. I'm giving you an IR. It doesn't have as long of a half-life as your controlled release or your long-acting will have. That's that page. And then this is just, again, what I just talked to you about. about weighing the risk versus the benefits and tapering a patient off, not leaving them on there long term, especially if it's not something that is a chronic condition. Just because they have a chronic condition does not mean that you have to leave them at the opioid dose that they have. You may have to, okay? There's nothing wrong with that because each patient is different. But in every situation, just because I have a chronic condition, just because I've had surgery on my ankle 10 times, does not mean that you have to leave me on an opioid for the rest of my life, okay? And then you see the longer duration of use, so greater than a year, you're going to taper by 10% monthly. That's going to take you a long time, right? So just think about trying to limit how much, and essentially what this is saying is you're trying to limit how much of an opioid and the duration of you exposing that patient to an opioid so that you're having less taper, less addiction, less tolerance, less side effects, and death whenever we're talking about opioid use. We talked about when you're giving them a prescription, giving them the smallest amount that you can for the condition that they have. Typically, that's between a 4 to 7 day supply. And that's all that I needed y'all to know from that. This last slide, just looking at those high risk patients that you'll see there. So sleep disorder, like they have obstructive sleep apnea, right? So that means they already probably have some type of breathing issue. I'm going to compound it. All of this makes sense. An older person, a pregnant woman, someone who has substance use disorder, so they're easily addicted to medications. They have abuse potential or addiction that runs in their families. A lot of your patients will come in and tell you that they don't want an opioid because of that. Try to ask them those questions and you be aware of it so that you know what you need to do for that patient as well. Oh, PMP. So, prescription monitoring program. Every state has a PMP, and what happens is when a person picks up an opioid, their name and the medication that they got and the quantity goes into this database. So when we're filling something as a pharmacy, we can go in and we can type in John Doe. And John Doe is coming in now trying to get their oxy. And I'm like, oh, you just picked this up yesterday. It also tells you if they paid for it cash or if they use their insurance, because some people try to get very smart and not go through their insurance, who will say, you just got this yesterday. So they'll pay cash and then they'll try to go somewhere else and use their insurance or vice versa, or they'll just pay cash altogether. So what the system does is it essentially like logs everything in there, and I work at Walgreens and I can see that somebody filled at CVS, I can see that somebody filled in an MTF, and I can deny that patient's prescription and be like, hey, you just got it, you have to wait until this date, blah, 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 give them their prescription back, and they get upset at you or me. And so you also can use the PMP and check to make sure that your patient is not only having you as their primary care provider, but a pain clinic. And they're using both of you to write prescriptions for them. It happens a lot. Doctor shopping. You can also use your urine drug test. Now, I wanted to talk about this because some people will be like, I want to see if you're abusing your medication. Are you selling your medication? Whatever the case may be. You can use it for that, but that is not something that you are going to, it's not punitive to the patient, okay? You're not trying to be like, I'm going to withhold this from you because you did this, but just letting them know like, hey, we took your levels. I don't see that you're taking any of this. Is there something wrong with the medication? Since you're not taking it, I'm going to go ahead and stop, filling it. Have a nice conversation with them instead of being like, oh, I don't see it in your system. You selling it? How much money did you make? Let me have my cut. Like, don't say any of that. Don't make it punitive. Just try to let them know nicely that you're not giving them their prescription anymore, or see what their story is, because maybe they had a bad week and they didn't want to take it, or they felt sick and it was making them feel sick. There's lots of things as to why people could not take their medication. Tapering. All right, I do not need y'all to remember this, but we talked about it. Do you abruptly stop them? No. I will tell you the one instance where you will abruptly stop them, and that is if they have a true opioid allergy, which is less than 2% of our patients that we're going to see. So if they have a life-threatening, like they cannot breathe anaphylactic reaction, you're not going to be like, well, I got a taper you. Take them off of the medication, okay? That is your exception to your rule, okay? All right, our conversions. This is our last part. Here are some definitions that we already went over, so I'm not going to go over them again. And essentially what your MMEs are doing are they're helping you identify these patients who you could monitor more closely because you don't see it in a morphine dose. Maybe you didn't realize, like, oh, I'm giving them a lot of hydrocodone. Like, this might cause a lot of adverse effects for them. I'm over my 50 that I should be for the entire day. I'm increasing the risk of my side effects. Looking at the reducing the risk of an unintentional overdose, right? Or reducing the fact that you need to taper them off of it. And not getting them to doses that are so high that will require a longer taper. So when you're switching from one over another, the biggest thing that I want you to take away from this slide is that we're mainly going to be looking at our full opioid agonists because of the other ones being partial or mixed. We don't know how they're going to act, right? So the conversion factor that they have is sometimes a hit or miss. So we're not going to touch on that at all. Y'all will not be doing that in practice for the most part unless you go to specialize in pain management. Go to a pain management specialist because there's different guidelines that they will use to follow to try to convert those patients if they're trying to get them on like a partial or a mixed agonist. When you talk about incomplete tolerance, what that is increased sensitivity to an opioid when you're switching from one class to another class. So that's why we'll convert to our MMEs, we'll get our daily dose of what we're going to be giving that patient, and then we will account for incomplete tolerance if we are switching a class. This only matters if you are switching from one drug to another. If you are just switching the formulation, this does not matter. So if I went from IV to PO, you all right over there? You causing a ruckus? If I just went from IV to PO, I don't need to worry about incomplete tolerance, cross tolerance. But if I went from meperidine to fentanyl or from one drug to another drug, that is when I am going to need to worry about the cross tolerance. If a patient is tolerant or if they are opioid naive, you can also probably give a lower dose. Okay? So looking at that is essentially what this entire slide is telling you with a lot of words. Our conversion charts, depending on what website you use, there are going to be different conversion charts. They are going to have different conversion factors. It is up to you, your clinic, like see which ones they like to use, fall in on whichever one they use. Also make sure that you are using your clinical judgment. If it does not feel right to you, regardless of what that table is showing you, if you are like, I don't feel comfortable with this, or I feel like I need to decrease the dose further, then do so. Okay? Always use your judgment because these charts and these tables that we are giving you are only suggestions and guidelines for what you are supposed to do. On the exam, do what the guidelines suggest you do, okay? When we go through this. So our conversions, I'm not going to read this to you right now because it's not going to make sense. Essentially, we're going to get our daily dose. We're going to get the MME based off of that conversion factor that we see on our chart. And then we're going to convert it to our new opioid if we are going to change it to a new opioid. And then we're going to adjust for cross tolerance. Your cross tolerance adjustment is going to be between 33 and 50%. In practice, most people, and when you get out of here and out of testing purposes, what most people use is 25%. Okay? Again, these are guidelines and suggestions on what you should do. Some people don't feel comfortable having it be at the 33 to 50% reduction, so they do 25. In practice, that is fine. For your exam, 33 to 50% reduction. If you are just changing the route of the medication, so if you are just changing PO to IV to whatever, whatever it is, you do not need to do step 4. And then when it says to create a new regimen, this also varies depending on who you talk to. But textbook-wise, when you create your new regimen, you will have your total daily dose and you will take 10 to 15% of that total daily dose and prescribe an immediate release for their PRN or their breakthrough pain. And that will be given to them every 1 to 2 hours. So that's how this is written. So this is that opioid conversion chart that I was telling you about and how you're going to get your MMEs. I'm going to go over like a little bit, y'all. I'm sorry. I just want to finish this so that tomorrow I can try to get y'all out on time. This is your MME conversion chart. I don't need you to remember the chart. If you need to do a conversion, I will give you the chart on the exam for you to know how to use it. So what we're going to go over is how you use it. Okay. So if I want to have 50 milligrams of hydrocodone, what I'm doing is I am going to take I'm going to look for hydrocodone, and you see here that it says 1. That's your oral conversion factor. So if my strength is 10,325, that's how they're getting the 50 milligrams. I'm going to have to do a problem because this isn't going to make sense to see it like this. We're going to do a problem. I'm just trying to, so for you to, when you go back after we do the problem, when you're looking at this, essentially you're multiplying your total daily dose by the conversion factor to get your MME. That's all that this is. But it'll make sense when we do our practice. And then as you see, the doses that are above the 50, we can increase our overdose risk, so we want to avoid that. And then the methadone, because of the variability, you see I've tried to put the box over it. Your fentanyl, when you're looking at that, just pay attention in practice. You see that one is micrograms per hour instead of all the other ones, which are milligrams per day. Okay? Again, if I need you to convert something, I will give you this table. You are not required to remember this table. Okay? This is just an overview of what we talked about on that 2 slides before for you to see what you should do. Same exact thing, just in a picture form. Some people like to look at pictures, aka skip this slide because you've already seen it. Okay. Now, our ways to calculate. Oh, this isn't working. This is when I need this. I'll sign into it tomorrow maybe if y'all don't get it. But our ways to calculate. You already know how to do calculations. This is similar as far as how you're setting up your ratios. There's 4 different methods that you can choose to do your calculations. It is up to you to pick which one you like. Okay? So if it's a 1-to-1 conversion, like there's nothing that you need to do. That's very straightforward. You're like, all right, cool, I got it. Because it's the same drug, there is no conversion factor that you need to take into consideration. You're only changing the route. So that's the one where I was saying you would skip that 4th step. When you're looking at your ratios, you have your actual doses and then your equal analgesic doses that you're going to get from the chart that'll be provided to you. So your total daily doses of your new over your old. And then the same thing for your chart, your new over your old, and you're going to solve for X. Okay? So you'll be solving for your new, which is your numerator on your actual drug doses side. It doesn't make sense looking at it. I'm just trying to talk y'all through it. I see the faces. I got you. It's going to make sense. When we do the practice problems, you can go through and try every way Try all, well, the first one is self-explanatory, but try 2 through 4 to see which one you like and to see which one is easier for you to remember, because you're going to get the same answer no matter which one you use. Just pick which one you like better, okay? New versus current, you'll have your new total daily dose over the factor that'll be on your chart, over your current total daily dose over the factor that's on the chart. Your fourth way that you have, this is the way that I like to do it because it's less confusing. You have your total daily dose, and then you're taking your factor from the chart of your new over the old. And then that'll give you the new total daily dose. To me, that is straightforward. Figure out how your math brain works. I will not tell you which one to pick. I'm just giving you 3 different choices on what to do, okay? We're going to do this one. So you place an order for 10 milligrams of oxymorphone daily, but the pharmacy doesn't stock it. Y'all going to run into that all the time. Don't yell at us. Instead, you decide to order an equivalent dose of hydrocodone. What is the morphine equivalent dose? That is your first question. So what is our total daily dose? 10 milligrams, right? I gave that to you. And what was the drug that we were using? The oxymorphone. So you go and you find your oxymorphone on the chart, and your conversion factor is 3. 10 times 3, 30. That's your answer. Your MMEs is super, straightforward. Get your total daily dose, multiply it by the conversion factor. Now, what if I said I had Opana and they were taking it 3 times a day?
30 times.
Right? Yes. So 30 times 3. Because now my new total daily dose, I have to multiply times 3 because they're taking it 3 times a day. Okay? So get your total daily dose, which is my dose that I took in that full 24 hours. Multiply it by your conversion factor, which will be given to you, and then you'll get your MME. Now I said, what is my new hydrocodone equivalent total daily dose? So this is where you will pick which way you want to work your math problem. So for me, I said that I wanted to do my total daily dose, which was 10, times my new conversion factor on the top, so that's 1 because I'm changing to hydrocodone, over my old, which was Opana.
Over your old MME or your old daily dose?
My old conversion factor. What happened? So my answer that I'm going to get is 3.3333333, right? So D would be my answer. If I wanted to, sorry, D is not my answer. I didn't mean to tell you that. Because I'm changing from oxymorphone to hydrocodone, what else do I need to do? I need to reduce it because of the cross tolerance, right? If I was just changing from Opana to Opana, I wouldn't need to do that. But because I am changing from Opana to hydrocodone, I need to reduce by that 33 to 50% for my cross tolerance. I will make it very obvious. You can pick whatever number you want to in between the 33 and 50%. I will try to make it the answers, the math problem, if you get one of these, very obvious as to what it will be, regardless of which range you use.
But you could do that only if you were switching, like each term and taking oxymorphone for whatever reason.
He didn't. So I ordered oxymorphone, but wait, ask your question.
Like why would I even do this if I'm putting him on oxymorphone for the first time?
Did you?
It's like I ain't got it. Then wouldn't I just look up the recommended dose for the new one?
Yes. You could, but this is not necessarily for every single person who like this time I don't have it. I didn't tell you if this person was opioid naive. I didn't tell you if he's had it before or not. He could have been on it and I just don't have it this time that he came in. In theory, in real life, you're going to look this up, and in real life, you have a calculator for this. You also just need to know how to do it by hand. So also when you look it up, even if a patient has been on an opioid before, you will see dosing for opioid naive versus someone who is not opioid naive. They'll give you two different doses because usually the opioid naive person will have a smaller dose than a person who's been on any type of opioid because of tolerance.
So like, if I was, I mean, I've taken an opioid 10 years ago. The last time I took it, am I not opioid naive?
It depends on how long you took it for.
Like 2 days, and I got my weapons.
Okay, so then no. You just trying to be nitpicky and make us stay in here longer. Everybody ready to go. When you see this for your exam, you are going to calculate it. Don't think anything outside of it besides calculating it. That's it. Realistically, you can look up a dose, you can send them to pain management, you can call your pain management pharmacist because you'll probably have one of those. But it will tell you for patients, usually when you say someone who is not opioid naive, that means that they've been on opioids recently and they've been on them for a long time. Over a year, over 2 years ago, even sometimes months ago, it's not going to do anything, especially if you only took it for a couple of days. I would probably treat that person like an opioid naive person. And that's what I said in the very beginning. A lot of this isn't black and white as far as like how you would manipulate these patients. So what I'll do on the review is I will put the way that you solve it and the explanation in there, even though I probably shouldn't, but I'm going to put it in there for y'all so you can see it and kind of walk through why we do what we do. So in this situation, for it to be simple math, what you would do is I just reduced it by the 30, I did 33%, I didn't do simple math. So I did 33%, so that's why you'll get C. But if I didn't reduce for that cross tolerance, the answer would have been D, which would have been the wrong answer. Okay? So that might happen on the exam, because y'all know we like to give y'all easy questions. Okay, this is another case very similar to what we just did. What I can do with this one, I can let y'all sit on it. If you have questions, you can just come to me, but I'm going to just go to the solution on how it works and what you would need to do. So this patient is taking 6 Percocet a day, and the oxycodone portion of it was 5 milligrams, so 6 times 5 is 30. That's their total daily dose that they have. And then I have to convert it to the MME. I would again give you that chart. So it's converting it, they're multiplying that total daily dose by the conversion factor. So we're talking about oxycodone. So let me go back. You see how you see the 1.5 there on the chart? So that's why we're multiplying by 1.5 here. So my 30 times 1.5, and I have about 45 MMEs. Because I'm only converting to a solution because this patient can't swallow, I don't need to worry about doing our other step that we were just talking about with the cross tolerance. Right. So now I just need to convert it based off of what strength they have that solution in. So that's your last step. Did that make sense? Somebody say no. Okay. Yes. So then this is just them solving for the regular math that you learned how to do last semester. And then the